Uh, Hearty welcome to all the registrants for this MTFI webinar on the elbow complex, and people across the world have shown a lot of interest for this webinar, and all those who are watching, because there are different time zones, so many are wishing, and my hearty greetings to all of you. For better buffering, we will be in the YouTube and better processing. Every 15 to 20 minutes, I'll be taking 1 minute break. So this is the part 1 of the continuing video, and then maybe with 1 minute break again we'll be commencing, and that also. So coming to the hold the phone. Yes. Coming to the elbow complex, and I have made the session primarily practical based, and we'll be having a practical demonstration, and I'm live from Manual Therapy Foundation of India head office at Mangalore, and it is a very critical juncture for all of us, and many of us are at home due to COVID-19, and I wish that all of you should be safe and stay healthy and stay safe. And at the same time, I'll attempt to take you on explorative journey through the elbow joint. And you see the elbow joint complex is comprising of the humerus and the ulna and the radius. And basically, as physiotherapists, very often we come across the issues of the elbow complex, and one of the common problem what we come across is the tennis elbow. That is one condition, and other condition is fracture disease following the stiffness, falls. So there can be injuries, and there can be the stiffness. The elbow, and as I told that we have already announced that from the content of this particular session, we'll be putting at the end in the maybe third or fourth part of, as I told, that we'll be taking some slight break every 12 to 13 minutes, so that there is better buffering from YouTube, and then you can go through this, and then you have to answer 10 questions, and out of that there has to be 5 correct answers, so that we issue your recertification. So coming to the humerus, the ulna, and the radius, you see the inferior part of the humerus is convex, and the radial head, which is the humero-radial joint and humero-ulnar joint. These are the 2 important joints as the association of the humerus, radius, and the ulna, and then we have the superior radio-ulnar joint. So what variety of joint here is, this is the convex, and here the head of the radius, it is concave. You see the concave surface is going to move with respect to the convex. So keeping the view of the concave convex rule, when a concave surface is going to move with respect to the convex, so then the bone and the glide are in the same direction. That means to facilitate the flexion, as far as the humero-radial joint is concerned, we have to give posterior to anterior glide. And here, as far as the humero-ulnar joint is concerned, you can see again this is concave, the superior articulating process, and this is the olecranon process, and this is the coronoid process, this is the coronoid fossa, and this is the convex, and concave surface is moving with respect to the convex. So here what happens is, in order to the various glides I'll show you now for the humero-radial ulnar joint, what are the various glides. Especially we have the posterior to anterior glide here, as far as the radial head is concerned, posterior to anterior glide. Then we have the anterior to posterior glide, and then the humero-ulnar joint, we have the caudal glide, cephalic glide, and yes. So the caudal glide, cephalic glide, medial glide, and the lateral glide. So if you have got any issues related to the question, what you do is you just write down, and we'll be having the towards the end part of the session you can put those questions. You can just write and I'll answer it. And right, so these are the various glides I just mentioned, and I'll show you the practicals now with the model. And slide down, yes, and then so simultaneously I'll be showing the to that side. Just focus here. Okay, right. So as I just mentioned, I'll show you now the radial mobilization from the lateral aspect of the elbow. I palpate little down, and about for a safe palpation of the radial head, you can palpate about 1 inch inferior to the lateral aspect of the elbow, and then you slightly elbow is flexed, you pronate and supinate, and slightly put the elbow in flexion. Posterior aspect of the radial head, just palpate as I told you, and that to confirm that you are at the radial head, you do the supination and pronation, and then you give posterior to anterior glide. You can give the posterior to anterior glide. Yes. And then give, this is the PA glide, posterior to anterior glide. And we can apply the various grades, grade 1, 2, and especially whenever we have got stiffness, we start with grade 2, then we can progress for grade 3 and then grade 4 mobilizations. And just to show you more efficiently, you can see I am palpating the radial head and I am giving posterior to anterior glide. And PA glide is applied whenever we have got restriction of supination also. When there is restriction of supination, we can go for the posterior to anterior glide. And when there is pain and restriction towards pronation, that time we will give AP glide for the radial head. And again the PA glide, as far as the this is about the superior radial nerve joint, and the humeroradial joint, PA glide is facilitating flexion and AP glide is facilitating extension for the radial head. So that was about the PA glide, especially facilitating the elbow flexion, and as far as the supination and pronation is concerned, the PA glide is going to facilitate the supination, because here the convex surface is moving with respect to concave. The next, coming to the AP glide. For the AP glide, you palpate pulp of the thumb anterior to the radial head, and then right, and then give anterior to posterior glide. We are palpating for the anterior aspect of the radial head. As I told you that the radial head is the annular ligament, and whenever there is dislocation of the radial head, the annular ligament is getting affected. So from there you can give the AP glide. Right? So this is the anterior to posterior glide. As I told you that from the radial head anterior aspect, we are giving anterior to posterior glide. So AP glide, the PA glide, and then we have the AP glide. Right. And next, coming to the ulna, come to prone lying position. The subject is in prone lying position, and okay, go little that side, slightly, right, and then you can see here, just focus from there, right. Okay. So we have the caudat glide. You see through the olecranon. I can apply the caudat glide. The caudat glide is to facilitate the flexion, and the cephalic glide is to facilitate the extension. Then we have the caudat glide, cephalic glide, lateral glide, and the medial glide. So here what we can do is we can place the pillow here for a better support, and can give the caudat glide. You see the caudat glide to the olecranon, give the various grades. This is to facilitate the flexion. And then cephalic glide to the olecranon, give the cephalic glide with the various grades, grade 1, 2, 3, and 4. And then we have this is the lateral glide. So lateral glide, basically if you palpate your own olecranon and then you take it for extension, you can just see how it is moving. And for extension and flexion, we have the various two glides. You see, this is the lateral glide from the medial aspect of the olecranon. I am giving the glide laterally, and then from the lateral aspect, I am giving the glide medially. Medial glide is applied primarily to increase the extension, and the lateral glide is applied to increase the flexion. So we have the caudate glide, cephalic glide, lateral glide, and the medial glide. So these are the various glides as far as the humero-ulnar joint is concerned and the humero-radial joint is concerned. So I'll just put a small recapitulation through the yes, I'll just put a pre-recorded video just as there are some that there is issue with a little bit of visibility. You can see here the subject is in supine lying position. Right, and the subject in supine lying position. This is the radial head. I am palpating. And so if somebody is having a difficulty in visibility, please adjust. There can be network issue from your side, because from our side some are so these are the various along with the mobilizations we have the other movements we have to check. These are active movements with overpressors. Now especially if we have got movement restrictions, we are checking for that. And as you know, normally the end fill towards elbow flexion, it is tissue approximation. Now suppose somebody is coming with some kind of stiffness, that time we can check for the movements, active movements with overpressors, flexion with overpressure, extensions with overpressure. And basically if there is movement restriction, we have to check for the end fills. Now you see now it is a tissue approximation end fill. And if there is towards flexion, if there is bony end fill, then it could be some malunited fractures. We have to check for extension also. Right? So these are the active movements with overpressors. And next I'll be just showing with those glides. You can see here. Already I demonstrated once again. There are some requests to demonstrate the glides, and this is we palpate lateral aspect of the elbow, about 1 inch inferior, and I am doing the pronation and supination. And then once you palpate, then we can apply the PA glide. The PA glide to the radial head is applied to increase the supination or to increase the flexion. As far as the radio-ulnar joint is concerned, you see this is the PA glide, posterior to anterior glide. I am just palpating for the radial head and giving posterior to anterior glide. You can see here. I am already repeating it. And the next it is that was the PA glide, and next I'll be just this is the posterior to anterior glide. Very useful in case of along with the treatment of tennis elbow, when we have got the involvement of the muscles, you have to also see that mobilize this PA glide, the radio-ulnar joint, and that is quite useful. This is the AP glide. Anterior to the, and those of you who are missing here, you can just refer in earlier. I have already demonstrated on the skeleton. So post PA glide and then AP glide. So in case of tennis elbow, we can apply the radial head mobilizations. It's very useful, especially the posterior to anterior glide technique is extremely useful. So this is the humeral ulnar joint. I already mentioned earlier part of this presentation, you can check. And this is the this is the caudate glide. Caudate glide is applied to increase the, you can see the closer view. So this is the cephalic glide. Cephalic glide is applied for extension. For the humeral ulnar joint, and caudate glide is applied for the flexion. This is very useful. Basically, when you have got involvement of the elbow complex, you need to work on the humeral ulnar joint also, and you need to work on the humeroradial also. And this is the lateral glide. And as I said, lateral glide is applied to increase the flexion, and medial glide is applied to increase the extension. And you can see here more closer view. This is the glides, yes, the lateral glide and the medial glides. And following these glides, I will be going for the special tests. And here, just for better buffering, I will be taking 1 minute break before I go ahead with the stability tests for the ligaments. And after that, I'll show you about the various techniques for the tennis elbow identification and the stability tests. I'll just cover up. I'll just take a small 1 minute break.